Welcome to this presentation. I'm Sue Kressly, owner and founder of Kressly Pediatrics. Thank you for the opportunity to present one of our case studies for the Davies Award. Kressly Pediatrics is a small, independent pediatric practice in Warrenton, Pennsylvania, a suburban community in Bucks County, approximately 20 miles from Philadelphia. I had been in a growing practice for 15 years before I opened a solo practice in 2004. The practice was founded with the vision statement you see here, combining traditional care and modern technology in partnership with families. As such, the practice began with selection of an electronic health record from the onset. In addition, the idea of using lean efficiency drove innovation from the beginning. The practice was started using a patient portal synchronized with the EHR back in 2004. This was not a commercially available product, but a disruptive innovation that was made specifically for the practice. New patients self-register on the patient portal, setting up a technology-enabled relationship from day one. In addition, watching inefficiencies of multiple handoffs in the pediatric office led to the decision to only have clinical staff in the office, which would perform both clinical and administrative functions. The practice began with one nurse, one MA, and one doctor. The practice has grown to 3 board-certified pediatricians. The staff now includes 4 RNs and 1 medical assistant who also serves as our biller. Yes, that's correct. 3 doctors and 5 staff. With a completely clinically oriented staff, this allows for all team members to be empowered to meet the needs of the family, and they are cross-trained, so vacations and illnesses have little disruption on office workflow. The practice is driven by the quadruple aim. Improving the patient experience of care has been with us since the beginning. Our staff says our practice is much like the sitcom Cheers. It's a practice where everyone knows your name. We have always been dedicated to improving the health of all of our patients, not just those who call us up to receive care. The healthcare environment in our region is one of the few in the country where the capitation payment model continues to exist for half of our patients. The other half is fee-for-service, so we have learned how to manage the total cost of care in order to have a sustainable business model. Commitment to ongoing practice transformation leads the way for improving the work life of our entire practice team. We all value the key role we play in our family's health and enjoy the relationships we develop and foster. There is significant personal satisfaction in being part of our practice team. The practice has a commitment to the medical home model and as such have been recognized as a Level 3 NCQA patient-centered medical home 3 times. Starting with an EHR in 2004, the practice foundation is based on capturing and using data to provide information so that we can increase our knowledge of both our patients and the care we deliver, and ultimately gain the wisdom on how best to deliver optimum care to foster optimum outcomes. The cornerstone of our practice is our dedication to the relationships we form and foster with our families. Whenever we reflect on how to approach a problem, we always include a perspective of the patient and family. All aspects of quality improvement revolve around the PDSA cycle of plan, do, study, and act. Most importantly, we have learned that projects which we plan often don't result in simple adoption when we get to the act stage. We have learned how to be open to adjusting our work and on occasion abandoning projects if we feel that they have not been thought out adequately, we don't have the appropriate technology, or for whatever reason, they're just not quite ready for prime time. For this case study, we will be reviewing our work focused on improving HPV vaccination rates. The background that formed the motivation for this project is the evidence that human papillomavirus is a very common virus which affects many teens each year. The CDC recommends HPV vaccination for girls and boys at the ages of 11 to 12 to protect against cancers caused by this ubiquitous virus. Data analysis has consistently shown that HPV vaccination coverage lags behind rates for other vaccines recommended for preteens. Our practice rates were well below what we wanted them to be. We were lower than our regional area's benchmarks. We needed to change from reactive to proactive population health management. In addition, the 2010 and HEDIS measures now contain HPV rates in addition to Tdap and meningococcal vaccines. We had 2 opportunities for incentives to improve. One was sponsored by Merck to get rebates if we implemented strategies to improve. The other was an ACO payer QI metric related to HPV vaccination rates. This is a slide looking at the vaccination rates for girls in our area from the CDC Teen Vax View from 2015. This is the corresponding slide for boys. What was our ultimate goal? To meet the 2020 Healthy People goal of 80% of the teens in our practice to have completed the HPV vaccine series. We elected to stratify our patients to be in compliance with our Pay for Performance program, which is completion rates by age 13 and then again by age 18. From the outset, we used a continuous quality improvement format with iterative PDSA cycles. This project in particular required physician education, buy-in, and collaborative strategizing. With a small practice, it also required buy-in from the entire practice team with frequent reporting back to the group so we could collaborate and improve at our monthly meetings. From our NCQA recognition process, we already had a PCMH quality improvement team, which we used to lead this work. Initially, we used one of our medical home monthly meetings, which is attended by the entire practice team, to understand our baseline performance, get buy-in, and set a realistic goal. We identified a project owner, agreed on how we were going to tackle this work, and identified technology efficiencies to be used. We implemented our plan while monitoring buy-in across the group, and along the way identified barriers to success and gaps in our work. We measured our performance repeatedly using available technology tools, reported them back at the monthly medical home meetings, and then adjusted our processes and our goals accordingly. This is an overview of our work, starting in the first quarter of 2014, and it continues to this day. I want to point out that this data is reported quarterly. Monthly variations showed too much variability in statistical significance due to our small sample size. Phase 1 really necessitated a better understanding of our baseline performance. In order to capitalize on some low-hanging fruit and build early success, Phase 1 of the project focused on leveraging existing functionality within our electronic health record. You can see that our baseline performance was significantly below the Healthy People 2020 goals. For patients 11 to 13, only 13% had initiated the HPV immunization series, and only 6% had completed the series. Our benchmark performance for all of our patients through age 18 was slightly better, with an initiation of the HPV series rate of 33% and completion of 22%. When we first looked at our baseline data, we heard a common theme. The physicians had an immediate data denial reaction. They were convinced they were actually doing better than our data demonstrated. It turned out that there was physician variability in the age of the recommendations. Some of the doctors really thought it was good enough if the patients got the HPV vaccines by the time they went to high school. And we learned through discussions among the doctors that there was physician variability in how strongly we were recommending the vaccine to our families. The benchmark data let us focus on the people and the processes first. The physicians needed to come to consensus about following best practice guidelines from the CDC and the American Academy of Pediatrics, which is to recommend the vaccine universally at age 11. We identified there were really 2 separate problems, the first being series initiation, which really needed to be led by the physicians, as the initial order comes from the physicians. And the second was series completion, which really involved the staff scheduling and following up to make sure the series was completed once we started it. The entire practice team was involved in formulating workflows. Our initial focus was on series initiation, as you can't complete what you don't start. Our electronic health record office practicum comes with embedded vaccine forecasting logic, which follows the Advisory Committee on Immunization Practices, or ACIP, recommendations. We needed to leverage this existing clinical decision support, which was already available to us. The vaccine forecasting logic is visible in multiple places within the electronic health record, including the face of the patient chart, while entering a message, or when scheduling an appointment. Quality improvement team educated everyone about this functionality that already exists in the software at our monthly medical home office meeting. We created an informed workflow so that anyone and everyone who touched the patient chart would be aware the patient was due for the HPV vaccine. The entire practice team agreed that once the awareness was there, we would all make strong recommendations to initiate immunization. We leveraged additional clinical decision support in our electronic health record by adding HPV vaccine as a routine immunization in our well-visit templates for all age groups beginning at age 11. Having the vaccine marked as routine on the well-visit template made it easy for the physicians to order the vaccine with one click. Initially, our focus resulted in some success, but our performance waned after a few months. We identified barriers, including there was a hesitancy in our community and among many of our families to initiate the vaccine series at this younger age. And there was a resistance among our team members to give 3 shots at the 11-year-old well visit. Physicians were reluctant to give a Tdap, meningococcal vaccine, and the first HPV at the same visit. And nurses really didn't like giving 3 shots to this age group either. In addition, there was significant variation among the physicians regarding their willingness to engage in sometimes difficult conversations with vaccine-hesitant families. Despite those barriers, by the end of the 3-month period, we were able to increase our initiation rates from 13% to 31% in the 11-year-old group, and 33 to 49% among 11 to 18-year-olds. This led to gradual increase in our series completion, and our entire staff was now more aware of our process, and our office was aligned. Nursing staff then initiated their own efforts to improve series completion. The nursing workflow initially was that after the first HPV was administered, they would schedule the appointment for dose number 2. If the appointment was missed for some reason, they would proactively reach out to those families, get them in, and then when dose 2 was given, make the appointment for dose number 3. The health IT we leveraged included the embedded EHR clinical decision support for vaccine forecasting, which also includes minimal interval forecasting on when the next vaccine in a series is due. We customized our well-visit templates, which are age-specific, to include routine administration of HPV vaccination beginning at the 11-year-old visit. We utilized the integrated patient message exchange of the EHR to send appointment reminders for vaccine visits. And lastly, we used the quality improvement calculator capability to create a custom QI report for HPV vaccine initiation and completion so we could monitor our performance. Phase 2 of our project focused on patient education and implementing new approaches to HPV immunization. Our benchmark performance for Phase 2 of the project was certainly improved over Phase 1, but you will notice by this graph, as depicted in this graph, it dipped from the initial gain. For 11 to 13-year-olds, our initiation rate was 21% with a completion rate of 17%. For 11 to 18-year-olds, we had an initiation rate of 46% with a completion rate of 36%. We began to work on barriers to success by making a concerted effort to make a strong recommendation, and one that was equal to the other vaccines being recommended. We also decided to move the Tdap vaccine to the 10-year-old well visit. This removed the barrier of giving 3 vaccines at the same time. We educated the physicians about focusing on cancer prevention and not even mentioned sexual activity in our initial discussions with families. We also had a concerted practice team effort to educate our families via social media, posters in our office about the HPV vaccination, and handouts. As we were working on this project, Merck created a program where selected practices could be eligible for vaccine rebates if we worked on HPV immunization improvement projects and reported our data. We were able to leverage our health IT, as there is a database viewer in our electronic health record where you can write custom SQLs and run them to collect data. We had this SQL written and shared it among the entire Office Practicum user base, as there were other practices across the country also involved in this program. There was slight variation in the metrics required for this program, but the goals were aligned. In leveraging our health IT, we changed the well visit templates in our EHR to have the Tdap vaccine routinely recommended at age 10. In addition, we can add patient education materials to the well visits, which are automatically presented on the patient portal when the appointment is confirmed. We use this to make sure that our families had information about the HPV vaccine prior to their 11-year-old well visit. We needed to adjust our workflow in that families were not scheduling their 3rd dose in the series, often commenting they would call back when they knew their schedule better. Our staff changed their practice to scheduling both dose 2 and dose 3 when the original dose was given. Initially, the nursing staff was hesitant because we only put our forward schedule in the computer 3 months in advance, and dose 3 should be given 6 months after dose 1. However, we quickly realized that we could safely schedule a nurse-only appointment 6 months in advance, because if the office is open, there would be a nurse available. Families who were hesitant to schedule 6 months in advance, we reminded them that they schedule dental cleanings routinely 6 months in advance. We assured them that they would be in the schedule, they would get a reminder from us prior to the appointment, and if it then turned out that the appointment time didn't work, it would serve as a reminder for them to call us and move the appointment. This slide represents our adjusted office workflow, where both doses 2 and 3 are scheduled at the time of dose 1 administration. Reminders are set via the automated patient reminder system, and if an appointment is missed, staff follow up and adjust appointment number for the 3rd dose if necessary. During phase 2, we saw steadily improvement in both HPV immunization and series completion in both age groups. In addition, there was growing confidence among all team members on what we were doing. Phase 3 of this project focused on reducing provider performance variability and raising the bar on our performance. Our practice performance for the beginning of phase 3 for the 11 to 13-year-olds was 45% initiation and 28% completion. We realized that many of these patients eventually did complete their series, but either not in the quarter measured, remember there's 6 months between doses 1 and 3, or they were older than 13 by the time of the series completion, so they fell out of the numerator. For 11 to 18-year-olds, 61% of our patients had initiated the HPV vaccine series, and 49% had completed it. We decided that phase 3 required us to put some actions behind our strong recommendations. We agreed that we would demonstrate our seriousness about this issue by having parents sign a vaccine refusal form if they decline to get the vaccine. In addition, we added coded data to the visit note by using the ICD-10 for immunization not carried out due to caregiver refusal. This information also gets transmitted to the payer with the claim. And we also added the appropriate SNOMED code to the patient problem list for patient refusal of vaccines. This is a screenshot from the electronic health record showing the diagnosis added to the visit for vaccine refusal. And this is a screenshot from the problem list in the electronic health record where we added this coded data. which now can be researchable in the future if we want to use it for future information. This is also visible to patients on their portal account, and we began to sort this problem to position 1 in the problem list so that families would recognize how strongly we were behind this best practice recommendation. An additional opportunity presented itself at this point in the project. The ACO, which our practice belongs to, negotiated a new pay-for-performance measure around HPV vaccination rates. This was aggregated data among all of the ACO pediatric practices. In addition, the American Academy of Pediatrics has a program called Electronic Pediatric Research in the Office Setting, or EPROS. They were applying for a grant to use electronic health record data and use learning collaboratives to improve HPV immunization rates. Lastly, the Pennsylvania chapter of the American Academy of Pediatrics began a quality improvement project around this topic. The lead physician in the group could get maintenance of certification Part 4 credits for pediatric board certification if they participated. To support the ePRO's work, Office Practicum created a custom SQL query for HPV immunization rates according to the data definition they described in their project. The query supported the baseline data they needed as part of their grant application. Office Practicum enjoys a robust user community provider listserv, and the specifics of this SQL query were shared with the providers on the listserv. We created a Google spreadsheet for practices to record and share individual practice performance. This is a screenshot from the EHR database viewer showing the custom SQL query to support this project. The SQL was shared via email on the listserv, and then participating practices contributed their crowdsourced data. The raw data was converted to percentages for all practices to view and learn. What happened next was unexpected. Physicians are by nature competitive and looking to improve. A spontaneous learning collaborative resulted on the provider listserv. Providers were asking, who's that practice with incredible rates and how in the world did you make that happen? Practices across the country shared challenges and successes and also shared strategies to improve, which benefited our practices and our patients. What happened next was that our practice seemed to plateau on performance. The QI team owner had a suspicion there was really differences among the physicians with conversations happening inside the exam room. Some of our doctors are more conflict averse than others. As a proxy for assessing the strength of recommendation, we leveraged Health IT by creating a custom SQL query to identify missed opportunities to give HPV vaccine at well visits. And then we stratified the results of this by provider as a means to test this hypothesis. We also shared this query with other pediatric practices in the OP user community on the same email listserv. This is a screenshot of the custom SQL query in the database viewer. Our suspicions were confirmed, and that we identified the physician with the lowest performance and got her to sign up for the state AAP project so she could get MOC Part 4 credits and get additional assistance on making strong recommendations. She didn't do this alone. The project team included a non-physician partner. As part of the project, they continued to measure, report, and compare performance with 29 other Pennsylvania pediatric practices in the Learning Collaborative project. Together, they continued to identify opportunities to educate, implement, and improve. As part of that project, our practice has most recently started to ask and document in the visit notes the why of vaccine refusal if parents don't consent to give HPV immunizations during the visit. Phase 3 successes have shown continued improvement in both HPV initiation and completion rates across both age groups. The entire team is more aligned in strong recommendations across all providers, and we also have better captured discrete data for future study on our refusals. What is our practice value derived? First of all, we are giving improved patient care and following evidence-based guidelines. We have the potential with our improved vaccination rates of preventing a significant number of future high-risk infections for our patients, and ultimately this is cancer prevention. Our staff and practice report less stress since we all now seem to be more on the same page. While we are a small practice, there were some true financial returns on our investment. If you add up the additional revenue we collected on our vaccine profit, the additional payment for vaccine administration codes, our pay-for-performance bonuses, our Merck rebates, and our participation in the state QI project, we made almost $75,000 of additional hard ROI, and we used that monies to continue our hard work. Where were we at the beginning of 2017? We made substantial progress. We're still not at the 80% Healthy People 2020 goal, but we're getting close, and it's not yet 2020. At the beginning of 2017, for our 11 to 13-year-old patients, we were at 64% initiation and 57% completion. Our 11 to 18-year-olds are now at 73% initiation and 66% completion. We also have had to adapt because there's now a difference in the series where younger children under 15 only need 2 shots and older teens still need 3. It's actually been a help as we tell families that younger children get such a better response to the vaccine and coverage from doing this at a young age. They only need 2 shots. And if you wait until they are older, they need 3. More and more families are electing to do this at an earlier age range. Our work is not done. This is a continuous process that we will work to monitor and improve as part of our commitment to using people, processes, and technology to improve the care for our patients and to maintain a solid, sustainable business model for our small independent practice. Thank you for your time and attention.